Welcome, everybody. Give it a couple of minutes here as people connect to audio and join, but wonderful to see some familiar names. And Gay, thank you for agreeing to present a case today. Very, very much appreciated.
My pleasure.
Good. It's a good one. And we'll give it maybe a minute and a half, probably at 1:02 start. Ken, welcome. So Emma is connected to audio. Emma, welcome. Oh, we have Alaska joining in the waiting room. I'm curious to see who this is going to be. Maybe it's the entire state. We may never know. All right, another minute here, maybe less than a minute. We will get started. Welcome, everyone. Right. Well, out of respect for your time and appreciation for joining, we will get going with our next in our series of Providence, Alaska Project Echo Dementia sessions. So I am Chris Rhodes, a neuropsychologist down at the University of Washington and Memory Brain Wellness Center at Harborview, and your grateful facilitator for today's session. So I'm going to go ahead and share my screen, if that's okay. Hopefully you can see that okay. So today in our clinic, and thank you all again for taking time out of your busy clinics and days and maybe even a day off to join this series designed to improve the detection, diagnosis, and treatment of dementia in communities where people are living and by the providers who know them best. So I'm so glad that you have joined. Here are our hub team members. We decided early on, given the number of participants and team members, that we weren't going to do introductions, breaking with Echo tradition. But I did want to call this out in terms of, for those of you who are joining, where people are joining from, and more importantly, who's joining. So really, again, a lovely and impressive variety of expertise, locations, and just a really amazing statewide commitment to the work that you're doing. So if you would, maybe throw your name and your location and your role into the chat, just to try to get a sense of who's here. That always helps with designing some of the content and maybe what we talk about in the case study. So we are proud and pleased to offer CME, and that is for 1 credit, both for physicians as well as nurses and advanced practice providers. There are some disclosures here that are relevant. What I will say is that any relevant financial relationship has been mitigated and cleared, and there is no indication of bias or other kind of issues. If you perceive otherwise, please let either Dr. Eisenberg or I know, or make sure to fill that out on your surveys. We're always open to that. And then here is the process for claiming CME through the Swedish system. And I'm hoping that code is up to date. I'm thinking it is. If it's not, you'll find it in the chat, and as well as the emails that come out afterwards. And with that, I am going to stop my share and turn it over to Dr. Gomi, Dr. Reza Gomi, who is going to talk about behavioral and psychological symptoms of dementia. And after that, I want to thank Gay Wellman and the Alzheimer's Resource of Alaska in advance for bringing a case forward today, which is a wonderful case. I think we're going to have plenty to talk about. So I will stop sharing here, and I will turn it over to Dr. Gomi. It's a pleasure to see you again, and thanks for agreeing to talk about this today.
Of course. Thank you, Chris and Nancy, Mount Pacific team, everybody, for doing this Alaska-focused echo. It's a wonderful resource. I'm glad it's come together so well. Some of the attendees might recognize me with or without my beard from my Montana work. So I'm doing this as a kind of a little guest presentation. So all the credit goes to Nancy, Chris, and Mount Pacific team, everyone who really organized this great echo series. So you can see my slides. I will hit the present. There we go. Okay, let me know if there's any issues with sound or anything. I'm actually at the American Academy of Neurology in downtown Seattle. So this is the first in person in a while. So there's a lot of bustling. I think everyone's very excited to be here in person. So forgive me if there's a little bit of background noise. So we're going to focus on behavioral and psychological symptoms of dementia. This is probably fitting because my background is psychiatry training, and then followed up with behavioral neurology, and kind of neuropsychiatry is sort of synonymous, but focus on dementia, but really my groundwork was all in psychiatry. So I'm really interested in the behavioral symptoms when it comes to neurodegeneration. So I'm very happy to talk about this very important topic. Again, I know we jumped through some of these already, so I'll skip ahead. Just some conflict of interest, which they haven't changed for me in the last few years. So I do work with Brain Check, which is a cognitive testing company. And then I also, really over COVID is like once or twice, I gave a dementia talk for Biogen. Let's see, and you guys know all about the CMEs. Okay, so we'll just jump right into the talk, and then we'll make sure there's enough time for the case presentation. Here we go. So some of you will recognize, so some of the material, I added some material as well. So some of this overlaps with the Alzheimer's Association material in these echoes, and then what I presented also last month, a couple months ago now, and across our other echo series. But we're going to get more into both non-pharmacological and pharmacological interventions, spend some time on the medication piece, because it's very difficult, challenging topic with not a lot of great, clear evidence. So just do what we can with that. So we'll talk about, of course, behavioral and psychological symptoms, and then we'll end up at the case. This 84-year-old dementia patient living at home. So really the focus is, when we're all out there working is, we want to be able to recognize behavioral and psychological symptoms of Alzheimer's disease and related dementias. I mean, the fact of the matter is that's the rule, not the exception, right? So everyone living with dementia will display some behavioral, so we call symptoms, are really just normal behaviors that really are seen out of context in most cases. And so we're going to learn through these slides that context is everything. And if we, the more we can stop, put ourselves in their shoes, all of a sudden it kind of makes a lot of sense. And so why the focus is on the importance of determining what the behavior is communicating, what are they trying to say, and then how to manage those behaviors. And so again, I really like to focus on the behavior management because, most often I'm called, usually under stress, from facilities, whether it's a primary care office and I'm helping manage a patient, the provider, or a facility, a residential facility. And usually it's urgent, right? Oh my goodness, this person tried to slap their loved one, or, reached out and hit one of the staff at the facility. So I don't want to come off as a jerk when I say, hey, let's think about, like, what do you think's going on, when, the other person's saying, give me a medication, like, fix it now. And so I think one important thing to remember is behavioral approach is not meant to invalidate anybody. It's not meant to take away from the importance of addressing the issue. That's 100% going to get, but we're also balancing long-term addressing versus short-term addressing. And so often, because I'm taking care of these patients long-term, right, I'm seeing the downstream effects, the long-term effects of, let's say, like throwing an Ativan at somebody, or, a Benadryl, an anticholinergic. You might get a few hours of relief, sure, but what we're trying to focus on, medications often have some downstream effects that are definitely not what we want. And so that's the only reason sometimes it might feel like when you're having these conversations, it might not be what someone wants to hear right then and there, but that's really the intention. And so here, little kind of flow chart of the person-centered behavioral management approach. So again, we want to focus on behavior. So sometimes there's a lot of understandable, completely justifiable emotion tied into it. And so really want to find out, the behavior is, Mr. Smith is always knocking the medication out of my hand when I try to give him his medications every night at 9 p.m. Okay. And so I think we want to reinforce here being really specific and measurable with behaviors. So it's something we can track. Understanding dementia etiology. So what kind of dementia do they have? How it works will really help inform that, understand their behaviors. Their severity will inform it a lot, right? There's a big difference between mild and severe dementia and how we approach it. So what is asking that question, what is the behavior communicating? Well, then people don't just do random things. There's a reason for it. Understanding the person's history, of course. Everyone's a product of their previous experiences, right? I mean, most of our patients with dementia have a story. A lot of them have a history of PTSD or depression or anxiety or all kinds of other things. So that's all going to make a difference. Consider contentment, when are they at their best, and then identifying those target behaviors to increase. So we want to really focus on good behaviors. Diagnosis and behavioral disturbance. So again, the rule, not the exception, will happen at some point, unfortunately. So I like to really remind families. So Alzheimer's is kind of the more common presentations of neurodegenerative or dementias. Alzheimer's disease, so more memory-based, so that might result in delusions. A lot of confabulation is one of the words we use a lot. So kind of like filling in gaps of memory with things that maybe weren't accurate. Lewy body dementia, a lot of visual cortex pathology, so a lot of visual symptoms. Sleep-wake cycle issues, very common. Vascular dementia, initiation, multitasking. So vascular dementia can sometimes look a lot like ADD. So think of that a little bit, but it's taking your whole brain offline. So it makes it very hard to multitask, but really just string together a sequence of logical steps. And then affect regulation, frontotemporal dementias, disinhibition or impulse control syndromes. There's some famous versions that are not necessarily as common as some of the others, these behavioral variants that you see a lot of personality change, depression and anxiety. And then alcohol, we see, you do see a fair bit of Wernicke-Korsakoffs, and you do see some brain pathology, on imaging we see this, and there's a lot of confabulation with that as well. That can be a little non-specific because often with Wernicke's or Korsakoffs, you have a lot of vascular dementia as well. I mean, because inevitably the vasculature is damaged with long-term alcohol use, but it can be really damaging. And then the one thing to remember is all dementias come together at some point, right? So as they all worsen, most of the brain becomes involved, so they start to look more alike. That's why it's so important. This is one of the reasons it's so important to identify early and to really intervene early, because the later I see somebody, it's really hard for me to figure out what was that starting pathology, because also as you get older, pathology adds on. So, some of these, I've been to talks where, you'll hear, if we all live to 120 or 150, we'd all have, a high percentage of Alzheimer's pathology, Parkinson's pathology, Lewy body, that kind of thing. And so one thing to remember, and I think this reminds me a lot now because I have a young child at home, so it reminds me a lot of this, but until we're a certain age, and then after a certain point when we have dementia, we lose that short-term memory, right? So just like with a toddler who's still too young, if they're doing something you don't want them to do, and your response is, okay, well, it's 9 a.m. If you keep hitting your sister, I'm not going to give you dessert tonight. Well, when you take away their dessert, 8 hours later, they have no idea what's going on. They have no idea why. So same thing, if you have a dementia, if you have a short-term memory loss, you cannot remember to connect to the behavior and the consequence. And so the traditional, what we do most of our life, right, and most of society relies on, is this antecedent, as a behavior and there's a consequence, right? And then you learn, I had a consequence, okay, I'm gonna adjust my behavior. Someone with Alzheimer's disease pretty quickly it's not really gonna benefit them. And so that's another reason we focus so much on the antecedent. I want to address the antecedent. I don't want to wait to have a consequence, and that's honestly a majority of the counseling I do is, hey, like it's not working, like we're doing all these consequences. And it's okay that those are an idea because that works with, of course, a lot of age groups and a lot of other things, but it just doesn't work here. And so that's where the focus will be. So behaviors of communication, right? Part of dementias, most dementias, again, as they all merge as brain regions become involved, but some earlier than others, language skills decline. So what's going to happen if you can't communicate with your words, well, you're going to communicate with behaviors, right? Because you need to communicate. That's part of being human. And so what's going to happen? You need to remember that behavior is not random, right? It's adaptive for that person. Oftentimes with the combination of dementia, they may be going back to adaptive behaviors from when they were much, much younger. So adaptive does not mean effective, right? So something that was adaptive when I was 12 or 14 and surviving, a situation that wasn't ideal might not be effective when I'm 75 years old, right, as an adult. But their brain is not giving them the benefit of being able to sort through that. And it's goal directed. So learning what that goal is really goes a long way. And so here are the most common things that the behavior is communicating. I find it so funny. I just find so many parallels now with, raising kids. Our brains, so interesting in that way. Pain, very, very common. If our patients have pain, the older they get with dementia, then they're gonna have a much harder time telling you that they're in pain. Boredom, overstimulation, very common, especially as dementia progresses. I'll show a graph in a minute, but it's very easy to overstimulate people with dementia. And so you have to always remember, wait a second, this feels like a very, chill environment, a pretty chill day. Maybe not for that person. Understimulation, again, it's finding that balance because as the dementia progresses, you have to constantly find that balance. You don't want to understimulate them either because we all need some kind of stimulation, right, to keep us going. Depression, apprehension, so anxiety, nerves, or habit. Sometimes habits just really come out. Sometimes you get a lot of rumination or just persistent repetitive behaviors come out with dementia. Here's that graph I was mentioning. And so on the left is kind of a rough guide, MMSE. You can sort of roughly consider, like some of you might be more familiar with the MoCA, same scale, 0 to 30. For intents and purposes of this, you can kind of consider it similar as, when you're 30, you're might be okay. You're not screening positive. And as you go towards 0, of course, you have pretty severe dementia. And so what tends to happen in the early stages of dementia is understimulation, right? Oh, this person has Alzheimer's. Oh, okay, we just let them sit in front of the couch in the corner and not really do much. Well, that's, I'm just making up an extreme here. That we want to avoid that. But as their cognition gets worse and worse, the danger is overstimulation. So when they do have a severe dementia, when they are in those final couple of years, it can become very easy to overstimulate. And then all of a sudden that's driving certain behaviors that we're wondering about. And so sometimes it's about having a calm, very quiet environment for people in later stages. So mediators of challenging behaviors in dementia. We talked about pain, physical health factors, psychological health factors, right? So how you were raised, the environment, and then how you learned how to cope with those things, that all plays into it. If you have heart issues and cholesterol and diabetes and a lot of comorbidities, which are very common, that's going to play into it. Environment, task, and approach, social history, it's all tied together. Very, very similar to biopsychosocial approach, we call it, in psychology. We can't create a behavior vacuum, so behaviors compete in real time. The reality is in all of our settings with families, whether patients at home, whether they're in a facility, there's a lot going on. And so it's really hard to just kind of look at that behavior in isolation. There's usually multiple stimuli coming in. And so we got to be really patient with ourselves and with the situation because it can be hard to figure out. Sometimes it really helps to ask when that person is at their best. This is a question I generally ask people when the behavior's going. I say, hey, so when was the last time they were at their best? And oh, what did things look like then? What were you doing? What was their schedule like? Sometimes it's a matter of they got an infection, a UTI. Well, okay. Or their sleep cycle is messed up now, or, they haven't been eating as well. They're dehydrated. I mean, you can uncover quite a few things by going into some details there. Increasing frequency of desired behaviors. So if we focus on that, usually, well, there's less time and space for the undesired behaviors. So really just driving that point home. So I added some slides I had from before from a different, from some different material, just in terms of just initially talking on the non-pharmaceutical approaches. So, and I know in previous sessions too, you guys have touched on non-pharmaceutical approaches too. So I don't want to, be too repetitive, but just throwing out some data that, I'd come across over the last, decade or so of things that have been found to be helpful. And it's not surprising, right? So environmental modifications, it's so important to have structured routines, to really stick to that routine and not veer from it as much as possible. Keeping the environment consistent. Visual cues can be helpful. Some dementia memory units, if you do a tour through, do this really well, where they have like shadow boxes and like visual cues all over, so people can find their way around without relying on like, oh, what room number do I have, or what is my phone number, or things that have become harder with dementia. We start to use visual cues, especially if they're tied to memories, long-term memories, or certain emotions, can really promote some memories, which is great. Reducing overstimulation. So we know obviously there's evidence for that. Pleasant activities with or without social interaction. Some social interaction is important, but you don't have to obviously overstimulate people. But social interaction is really critical. When people are living at home, it can be really easily, especially the last couple of years. Boy, has that been a really, really tough time to have dementia, because it was very isolating. So getting people back out, the social piece is kind of one of those ingredients for healthy memory. So always keep in mind, are they getting enough social interaction? Exercise, critical. We all know this, but often when you tie this to memory, it's enough to get some more motivation or some more action from people. But helping with their sleep, getting them nice and tired so they go to bed, at night. Music therapy. I often bring this up, it's if you bring back music from someone's when they were younger, from their early adulthood, childhood, it can be really effective. It can really be just positive and really help their mood. So keep that in mind. That's nowadays, it's easy to get, and it's free. I mean, you can get music online anywhere. Cognitive stimulation therapy also can be very helpful, especially earlier in the course. This is, I'm not going to pretend to be the expert on this case. You have Chris here, who's done some amazing work with cognitive rehab type of training and therapy. So especially earlier it is, man, it's lucky when you have those resources, you can get patients to that. Reminiscence therapy. It's actually more and more trials about this. It's very interesting, right? So promoting, kind of thinking back to earlier memories. Ellen Langer out of Harvard's done a lot of interesting studies where she's basically like brought people back in time in a way where, you go like to an environment where like the cars and the music and the magazines, everything's like from the 1970s, let's say, and people actually they feel better, they do better. So it's been interesting. Group engagements is a way to kind of access certain resources that might be harder to access one-on-one, especially in rural areas in Montana and then in Alaska. Often it's easier to take advantage of some community group resources. Very effective because it really engages people. So that might be at the YMCA, there might be some adult day programs. Again, these things are all talking about addressing those antecedents, right? This is what we're all talking about, is how can I build a schedule, build a routine, and offer interventions so I don't get to those behaviors that can be very challenging in the first place. There's some evidence from Montessori program for dementia. Won't go into the details here, but these are all things you can read about. I wanted to just spend a few minutes on medication because I know that's always a hot topic. So the disclaimer is, right, there isn't, dementia is a tough thing to study for medication for obvious reasons, right? Because we have a whole population here that's difficult to consent. It's also difficult to track their symptoms. So controlled trials are challenging, but we do have some information. In recent years, and I don't know if they finished it, there was a kind of a multi-center trial going because it turned out citalopram, Celexa or S-citalopram which is a very, very closely related drug, turned out to be pretty effective, surprisingly, at the time, in reducing agitation and caregiver distress. So not just treating an apathy or a depression of dementia, but actually reducing this agitation piece. And so they've actually been going out for, I don't know if they've gotten it yet, but they've been going for an FDA indication for dementia, for agitation and depression and dementia. And I haven't seen that it's been approved yet, but it seemed like they had pretty promising results. So the point of the story is, if someone has dementia, they're getting diagnosed, in general, I'll transition. If they need to be on an antidepressant, if I'm targeting some mild agitation or apathy, I usually transition them to citalopram. I usually don't keep messing around with things, other SSRIs, Prozac, sertraline, Zoloft. Just for some reason, citalopram seems to stick out. And so I like to rely on that when I do. And in general, it's very safe. It does have a very mild QTC prolongation, but it's very mild. In fact, I counseled dozens of cardiologists with patients who have cardiac comorbidities that are seeing a cardiologist. I've never had one say, don't give them the citalopram. So I actually don't even bother asking anymore. I mean, you use your judgment, but I don't try to start it on someone. I'll give you the caveat that if they have, horrible heart failure, and their end stage, of course. But if they have just general mild disease, moderate disease, it doesn't seem to cause a problem. And you start at 10 milligrams, work my way up to 20, sometimes, push it even higher depending on the person. So citalopram stands out. The other big hot topic is antipsychotics. The thing about antipsychotics is, especially, it goes counter to everything we know about them when you're younger. So if someone comes in younger in the emergency room and they're, agitated, I might throw olanzapine at them, quetiapine even. They don't really work for dementia. And so it's very tempting to want to use them, but there's very weak evidence and they just tend not to work at all. So I generally don't prescribe these medications. I mean, out of all the patients I take care of, let me put it this way, less than a handful are on, quetiapine, olanzapine, a Haldol, Abilify. Abilify has some other side effects. It has some evidence for efficacy, but if, as a last resort, we're going to an antipsychotic, I usually go to risperidone because it seems to have some evidence, and generally it's tolerated in the older folks. Again, the big kind of warning is antipsychotics all come with a black box warning, right, of sudden death, stroke in the elderly, because they do have these metabolic risk factors along with it. And there is just this, we don't know exactly why, but there is a higher risk of higher mortality, high risk of death. So yeah, this is, when I say last resort, it's, I think about, if a patient's coming to me, it's already been filtered through so many people. And then of the patients that see me, it's still a last resort. So I really try hard. Of course, sometimes, it's necessary. And I have had, when I do use it in this very limited fashion, I've had good success with it. And what I also keep in mind is, it's easy to prescribe a medication and then forget about it for a couple of years. So I prescribe it, and usually a few months, they don't need to be on it anymore. Then I take it back off. And then maybe a year later, maybe it needs to come back. So just keep that in mind too, is always recheck, because especially as dementia advances, less medication, the better. The less you're messing with their metabolism, chemicals, and stuff that their liver has to track, their kidneys have to track, the better they do. And so again, just keep in mind, Zyprexa, olanzapine, quetiapine, Seroquel, really not effective. So I don't see much reason to really ever use those medications, because they don't help with the things we want to help with. Anti-convulsants, not great evidence. So I don't really use these in, again, if I'm treating something comorbid, like they have seizure disorders, that's a whole different story. But if I'm targeting for specifically agitation, not a lot of great evidence for anticonvulsants. Donepezil, galantamine, rivastigmine, cholinesterase inhibitors, not necessarily great agitation, but they do have effects on depression, apathy, and anxiety. So we do use those. They also have other long-term functional, gains, especially started earlier. So, and there's some evidence over the years that people with Lewy body pathology, interestingly, will have some benefit in terms of agitation potentially. So keep that in mind. But I'm a big fan of these medications, the few that we can provide. And if they're tolerated well, then great. And then Nmda receptor antagonists, of course, Nmda, which we all know, the other main medication. Small benefit potentially, but we use it for other reasons, especially at the moderate to severe stage. But we don't use either of these for acute agitation. I'll just just one chart that I thought is helpful to look at too. For sleep and helping people get back on sleep track is trazodone. I've had a lot of good benefit from that. It's a pretty mild medication. It doesn't have the anticholinergic effects that a lot, because so often we're finding people are on the Benadryls, the hypnotics, like Ambien. There's a, if we look up the Beers criteria, you just look up Beers criteria, that's always a helpful list of medications you want to avoid. So I'm always, if I'm using medication, I'm trying to start at the lightest level so that I'm less likely to cause memory issues. So we got trazodone here, we got citalopram, escitalopram versus risperidone. I mean, that's pretty small toolkit, but that's pretty much, those are pretty much my go-tos. You can see sertraline, Zoloft, which is one of the most common medications in the US, not very effective. But we use it so much in younger folks. We also use it in geriatric psychiatry, non-dementia. So you just got to keep in mind, once dementia is in the picture, it seems to lose its efficacy. And then mirtazapine, Remeron, we use a lot for sleep as well, but keep in mind, it's not necessarily as helpful in dementia for depression or agitation, but it can still make people a little bit sleepy. So sometimes we'll use that for sleep. And appetite, it can increase appetite. So sometimes if someone's having a harder time eating, we'll bring that in. But again, just keep in mind, so really just a handful of things, but the common theme is sort of last resort. Sleep, I'll tell you right now, I love helping people with sleep because I've never been able to, this is like my so few things in medicine where we can say absolutes, but I'm batting 1,000. If you follow cognitive behavioral therapy for insomnia techniques, you can get off your medications. That's pretty much, again, but I'm not saying it's easy. I'm not saying everyone can do it, but if you do it, that's how effective behavioral strategies are. They're extremely effective. But there's lots of factors that might get in the way. So don't take that as an absolute, but. So, okay, I just threw a lot of information, trying to make the focus on behavior, of course, and then just some, hot topics with medications. Any questions before we move on to the case?
I just have a question about the citalopram. I know that's where the most research is, but what about escitalopram? I mean, it seems like it has less side effects. So I'm just curious, why not that medication?
I mean, scientifically, so citalopram has these two enantiomers of like left, right-handed, of the molecule, and escitalopram is just one of them. So it's like the active one. So technically it's cleaner. I haven't had much difference in the way of side effects for people. So, I mean, I don't see any reason you can't use escitalopram, Lexapro, but I'll use either, but I usually just go with citalopram. But I just haven't had a big difference anecdotally of people reporting side effects.
Okay, thank you.
And this is Gay. I have a history in back of working with folks with a mental illness, and you mentioned that the antidepressants stop being effective, or some of them can stop being effective as the person develops. Is that true of the antipsychotics if someone has had schizophrenia or bipolar?
Sorry, you didn't say that last
and
piece
develop
again?
dementia. Yeah, the medication, the antipsychotics that people have been taking for schizophrenia or bipolar illness decrease their effectiveness the same as an antidepressant if they develop dementia.
That's a great question. So not necessarily if it's for psychosis, but what tends to happen is people with dementia, the dementia becomes overwhelming to whatever the underlying psychosis is. And so as the dementia progresses, I'll actually find that they don't need to be on their antipsychotics anymore. That I'll take away. Yeah, I'll take those things away. Yeah.
Good. Thank you. Wondered about that. Okay.
Excellent. Any other questions? And Reza, thank you so much for what a great overview. And it's always refreshing to see an emphasis on the behavioral and non-pharmacological things from prescribing providers.
Absolutely. Should we jump into the case?
Okay.
Unless there are any other, we'll give it the usual 10-second pause for Zoom.
I have a question.
See?
I thought I'd jump in. The behaviors around what we call sundowning, is that
yes.
Anything that comes to mind specifically helpful around people that seem to, around the time of the 5 to 8 o'clock time where maybe their sleep-wake cycle has been disrupted by dementia. Do you have any, does that give someone that gives a history of having agitation around that time? Do you look at melatonin ever being helpful, or specific behaviors around light therapy and activities that you counsel people on?
Yeah, absolutely. Lots of interventions in that scenario. Melatonin, not. I mean, it's not necessarily in terms of the agitation, but it can help you with sleep-wake cycle. The key to remember with melatonin, though, is when you're using it for circadian rhythm, is you just need a low dose. You actually need it 5 to 6 hours before their bedtime. So if their bedtime's 8 or 9 p.m., they really should be taking it 2 or 3 p.m. So keep that in mind. A lot of people are taking melatonin at bedtime. That's not the right way to take it, and because melatonin is giving your SCN nucleus the signal that the sun is going down. Well, you want the sun to go down several hours before you actually go to bed. So just keep that in mind. So you can sometimes move that earlier in the day. That can be helpful. But a lot of it is that providing a calmer environment. Like a lot of overstimulation is often an issue when it comes to sundowning, because especially in facilities, when you look, often like a kind of a busy time is at 5 to 8 p.m. because it's like evening meds are going out, dinners are going out, and it can just be overstimulating. So often you want to help people transition to a quieter environment. Sometimes move their evening meds earlier. So like in traditional hospitals, we give evening meds, 7, 8, 9 p.m. Got to be much, you can move that to earlier. So you can kind of give it with dinner or even a little bit before dinner if they're taking like their normal blood pressure, diabetes. Again, you want to not overstimulate. So the less I have to approach them when they're having their quote unquote sundowning. The sundowning is really just, right, it's just agitate. It's not being able to process too many signals. That's what's happening. And then people are feeling overwhelmed. And it comes out in that kind of behavior. That's really all sundowning is, because those are people with dementia that's progressed to the point where they really just can't parse through what's going on. And the sun is down, so it's less. They're less alert, and they've less orienting information. Because when it's dark, it's harder for me to know like where I am or what I'm doing, and I have a sense of time. So hopefully that's helpful. But a lot of those kind of behavioral things can help.
Good question. I've also had some pretty good luck with programmed naps or downtime as a preventative strategy to help people kind of reboot a little bit, but not always.
Excellent.
All right, other questions? We have Dr. Gomi here. If not, we will move on to the case. And Gay, do you want me to drive the slides? Do you want to? How do you want to do that?
You can do it. I'd be
Okay.
less. That'd be better for me. I can just let you know when I'm ready to go on, and you can tell by what I've said. Okay. I'm very pleased to be able to present this case. This is one that I've been, I won't say struggling with, but it's been a wonderful challenge. Let's put it that way, for about a year now or more. I've been working with the wife mostly. Most of my work is in fact, pretty much exclusively is done with the partners, the care partners. And right now I've been doing for about a year, a little over a year now, I've had 2 partner support groups that meet twice a month. And this is a case from that. This woman has been attending it regularly. And just as the doctor said that we need to pay attention to the history and background of the person who has dementia, you also want to be aware of what the family members have too. So what's going on for them? What kind of personalities do they have? What are the challenges? What are they able to tolerate? What do they can't? And so in tailoring whatever interventions or whatever suggestions you're going to be making, you really want to know who it is, how they're going to receive what it is you're giving them. So that's been one of the challenges with this woman. She's delightful. And I find myself getting to be really close to some of these folks because, it's kind of like we're trying to problem solve all together. So let's go ahead with this case. Her husband is about 84. He's been a professional man. He's very, very prominent. He was had a very important job where he was in charge of a whole group of things, and he was in charge of financial stuff. He was checking up on finances in I think it was the U.S. Postal Service or something like that. So he's a very important person. all his life. And he's very articulate. He was very personable. I've talked to some of their friends, and they said he was delightful to converse with, very intelligent, very knowledgeable, been all over the world. He and his wife used to travel a lot, and they had a pretty good relationship. She also, to speak of her, she was also a high-powered person in charge of things and used to getting her own way. And both of these are people that are used to getting their own way. When they say jump, you jump, right? So, and pleasantly, it's not bad, but pleasantly, okay? So she's got this husband now who's developing dementia. And over about 3 years ago, she started to really notice some real changes going on. And we're saying we think he's about an emerald state or early mid stage. Any of you that know about the Teepa Snow's GEM stages, I really enjoy working with those. Same thing, but it's just kind of nice to say somebody's in the emerald stage rather than middle to late. So anyway, my preference. About 2 years ago, the wife became the trigger. Whenever she was around, he was more likely to become very angry and upset and aggressive, was getting more and more so. And he got to telling her she had to leave. And she got to where she was feeling unsafe, especially with COVID, because he was no longer he didn't recognize the importance of keeping a mask on and was always going out. He'd been driving, he continued to drive, continues to drive, even though he's where he shouldn't be. But about 2 years, she found about a year and a half ago, she had to move out, and not permanently. Well, essentially she's permanently, but she goes back in around noon and stays as long as she can up until the time he starts getting agitated with her. The husband, as I said, can appear to be fine. Whoops, I've lost my slide. But to go back, and I'll let you know when I'm ready to move on to the next one. There we go. Okay. Okay. The other piece that on this part of it is that the part that she's been having a really lot of challenges trying to get the help that she feels she needs for her husband. She moved into a bed and breakfast, has been living in a bed and breakfast. They both have quite a lot of money, independent money, but combined, but also there's a lot of money involved here. And that becomes important a little bit later. He's a veteran, so she's been trying to get help from the VA, trying to get help from doctors, lawyers. And if, as I said, if they aren't doing exactly, what she feels they need to be doing, she's likely to drop them. And she gets really frustrated with it. She says that she's okay to deal with them in a professional, quote unquote, way. She doesn't express her frustration with them, but she certainly does with us in the group. So any service agency, she's just having an ongoing trouble. One of the things she says, everything you say I should be able to do does not work. That's where she's come to. Okay, next slide. Okay, progressive concerns. She reports that he was beginning to share financial information over the phone, like their card numbers and their numbers for the bank and things like that over the phone. She overheard him doing that. And he, of course, would get upset with her if she tried to tell him not to do that. He is no longer able to understand financial matters. And here, remember, here's a man it was his profession. And apparently he doesn't understand anything about banking at this point. He doesn't, but he insists that he does. And so again, he will not let her, he doesn't want her to have anything to do with it. She does have power of attorney, but again, power of attorney, as some of these folks are finding, is limited in some situations. Medications. He's supposed to be taking medications for various different health issues, and he's not taking them properly. And if she tries to remind him again, if she reminds him, it's not going to work. That's what he'll set him off. So she has to be pretty sneaky about that, if anything. The kidney medication he's supposed to take, he told her he's not taking it because the doctor hasn't prescribed it. Well, the doctor did prescribe it. The doctor's talked with him multiple times about the importance of him taking it, but he doesn't remember that. So he's not taking it. Increasing frustration when he can't manage his computer. He forgets how to do it. And so obvious signs of progressing dementia going on here. And again, becoming more and more belligerent. He's thrown things. He's threatened to pull bookcases off the book. And he's actually hit her once, not badly, and pushed her another time that she's mentioned. And it used to be that it was just when it was just him and her, but now he's beginning to show that with others. Next slide. Again, this is one of her big things. He can't plan or execute any plans. He's supposed to be getting a hip replacement. He's supposed to be getting all these different doctor's appointments. He won't let her make them, and he doesn't understand that he has to make them ahead of time. So he he takes himself to doctor's offices and expects them to see him right then, and then gets upset or gets frustrated with her, not necessarily with them, but he'll come back and get frustrated with her when they wouldn't see him. And he doesn't understand. He's no longer able to do that sort of thing, which would be something that in the past he would have done pretty easily, very easily. She's also discovered things burning on the stove when she's come in the afternoon. And she was there one time when there was an item in the oven that he forgot about. And so she's got some increasing concerns about his safety, obviously. His friends say, yes, he's lost his ability to stay safe on his own. He's struggling with word finding, has been for a while, and on phone conversations with his friends, repeating circular conversations, things like that. Some of the typical things that we see with progressive dementia. So next slide. This is what's happening now. This is what's escalating things. His wife previously had tried to get a guardianship. She was thinking that, she was feeling like, and we were sort of telling her like, hey, it sounds like you're going to really need to get that or get somebody to have that so that he can be safe. Because that's her big concern. Is that her concern is that he's not going to be safe or he's going to hurt somebody when he's driving. And so she's really, and he will not listen to anything she says. So she's realized she can't be the guardian, but she was trying to get that put in place. And unfortunately, it didn't happen the way she was hoping it could happen. It's a long process. And again, at one point, she finally just said, no, we're not going to go further, because he was going to refuse any kind of care anyway. And the person, the court visitor that came in to see him, apparently got kind of bamboozled by the fact that he could speak French and was very articulate about his past, and she didn't see any of the signs that she was looking for. And so the wife heard about this, and the lawyer she was working with said, it sounds like there's not enough evidence here to pursue a guardianship, especially since he's going to fight it. So anyway, about a month or so ago, she gets this call from the sister, who has not been in touch with him at all for years, ever. They've never been in touch. Well, now suddenly here comes his sister with her daughter saying, okay, he can move down with us and we'll take care of him and we'll get guardianship. And then they started when she said, well, okay, sounds like an okay thing, we can explore it. But they wanted all the information. They wanted his bank account numbers and everything. They wanted all the information from the VA, and obviously sounding like this isn't going to work really well. And then they told her she should get a divorce and that they would take care of everything. They even told him on the phone that she found out about this because she came to visit one time, and here he is with his bag packed and walking out the door and saying that his sisters told him that she's going for a guardianship and that she's going to bleed him dry. And of course, he was pretty upset by that. And she's learned apparently how to help him calm down, but it takes a lot of energy from her and it doesn't always work. So she got him back in the house apparently that time, but apparently it's continuing to go on. He apparently has told a friend that, when the friend asked him about that, because he'd heard about it. And he said, well, it's too hot down in Florida. So that's his reasoning for not going there, but he's still not happy with his wife. The other thing that just happened recently, that the doctor that they've been seeing, the doctor was finally saying, you need to go and get your driving test tested. And he apparently blew up in front of the doctor and stormed out. And that was the first time he's done that with the doctor. And the doctor told the wife that he would go ahead and file an APS report to try to get things under control. And then last week, now been a week and a half now, he finally had a car accident. Expected, really, but up to now he'd been managing fairly well. She doesn't drive with him because she's been told that if she's in the car with him and they have an accident, she's liable because she knows he has dementia. And so she doesn't drive with him anymore. But he had this car accident. Luckily, it wasn't very serious. It was a T-boning. He was trying to turn left and he got T-boned. Apparently nobody got hurt, but he didn't give the proper paperwork to the other driver. She has not heard what's happening with that. The police did come, but they apparently didn't cite anybody. And as far as she knows, because it's her husband who's reporting it. And so she doesn't know for sure what's happening with that. A little bit of additional information. Actually, we can go ahead with the next slide because that's the next
So,
one.
Gay, I don't want to cut you off here, but I do want to let you know we have 10 minutes and we have a lot to talk about with this case. So I'm wondering, do you want to, how do you want to go for the last 10 minutes? What's going to be of most use to you?
I think what's going to be most useful if we look at the last slide and you can see what we've done. Okay, we have, as I said, she's applied for guardianship. She has had a CIT officer come and visit at the home because she was feeling like she had to call 911, and that's been wonderful that she's been able to do that. Let's see, she's trying to get as much collaboration as she can because mostly of his behavior is with her, not with anybody else. The bank manager and the doctor now know. She's considering applying for conservatorship rather than the full guardianship. I filed a protective order with all of this in it with APS, and I was told, what I was told to do was to get the wife to make sure the doctor has done an APS report, and also that he should contact DMV about getting the husband retested and have it come from the doctor rather than from the wife. Whether that's going to do anything, who knows? Okay, that's basically it. So what do we do? What's next?
Well, first and foremost, thank you for presenting that case, and I think you've highlighted the complexity and the safety issues that are so familiar to so many of us.
Right.
And I'm curious. I've got a couple things that I'm happy to chat about, especially around driving. But I'm curious what our community, what are you thinking? What would you recommend? What questions do you have? Feel free to unmute and maybe say your name and go for it.
I'd love to hear some ideas.
Go ahead. Actually, I think Emily just came off.
Hi, yeah, I'm an occupational therapist. And Gay, I think we were on the call a couple days ago together, but
yes,
my thought is with this car accident, it's for me, I said, is this an opportunity to get the car out of the sight of this man, because it probably is either totaled or needing work, and then removing the car key, so you're kind of removing the visual stimulus of this car, and if he asks about it, it's more like, well, it's in the shop, that type of a thing. I don't know if that might be something to redirect him away from the driving.
possibly. It sounds like that he's already going out to buy a new car. And again, she has no control over him at all. Any efforts she makes to control what he does. So it's going to have to be someone other than the wife. But you're right. And I think what she can do, that's kind of like, he's got the money and he's got the chutzpah to do it. He's still okay with that. He's functional enough to do that sort of thing. But unless she goes around to all car places and says, don't tell him anything.
In these situations, I think what ends up happening, because these are the kinds of cases that usually come across my office. I think what ends up happening is it's so easy to end up talking to so many people, because so many people in his family are involved. There's lots of cooks in the kitchen. I always start with ground zero is you got to build a rapport. I'm not saying you haven't done this. I'm just saying I build rapport with the patient one-on-one privately. And so usually I'll ask everyone else to leave. I'll make sure it's a private meeting. And usually they're pretty good, historically can build rapport, especially if you're really then building the trust that, hey, I'm here for you. What's your goal? You want to stay home and independent? I will make that my number one priority, and I will work with you to do that, and then try to build that bridge of, well, these are the reasons if you decide you're going to retire from driving in these ways, well, it's actually going to keep you at home longer. You're going to stay safer. I try to see what can I appeal to in terms of their motivation. Right now, it's hard because you have a lot of loud characters in this, right? You've got this loud sister, you got a loud this, you got a loud this. It can be really overwhelming. And so I try to like clear out that that stuff. You'll have to obviously work with them, but really the patient is the person with dementia. And then usually you can have some pretty good luck there, and then start there. And then you can kind of go from there. And then if, again, as a last resort, if you're really worried that they're going to hurt somebody or they're being extremely reckless, sure. But I'll tell you, actually, in all of my time, it's actually interesting. I probably sent 2 letters to the Department of Motor Vehicles in all my practice. I mean, it's pretty rare that ends up having to even be necessary.
Those are really good suggestions. I think that the doctor that they've been working with, that was his approach, that he was asking the wife to stay out of things more. And again, I am not in a position to personally been in a position. I live out in the Copper Basin, so I don't know any of these people in person other than in little boxes. So I've never met the client. And I don't know that he's met anybody from our agency. I do not think so. He has been in touch with people at the VA. And again, but anybody that brings up any mention of cognitive decline, if they go anywhere close to that, he storms off and doesn't see them anymore. There is one provider that he has been talking with that apparently has been a little bit more successful in doing that. So what kind of would it be? The wife would get in touch because the husband's not going to be giving accurate information at this point. And you know, that's part of what my job is, to how do I help the wife to back off or to
This is often a time too to consider. Usually at this point too, I'm really pushing pretty hard for folks to have somebody like caregiver support to come in the home. And usually that's framed as, oh, you don't need any help. They're just going to help you do some housekeeping. They're going to help do some stuff that like he doesn't want to do, not suggesting that he needs a reminder for anything. Get somebody, because then you get an impartial third party, you know, eyes in there. I push pretty hard on that. That's usually, especially at this point, because yeah, I don't think the wife unfortunately is in a position that there's a lot of history, there's a lot of momentum there. It can be really hard to change direction.
Okay, that's a good point, and we'll see what we can do with that.
The other 2 things I want to point out, one in the chat. Thank you, Liam, for putting the link in for the way to report individuals for whom you have concerns to the Department of Licensing, the Department of Motor Vehicles. Alaska is slightly unique in the WAMI region in that those requests will be kept confidential. Unlike here in Washington, if somebody calls up and says, who reported me, they will let them know. Alaska does a pretty good job of keeping things confidential unless an administrative hearing has been requested, and then it may be necessary to release that. So there's a little bit of a level of protection. That's something important to know. And then thank you to Karen also. Do you want to unmute and make that comment?
This is Karen Kelly. I run the Homer Senior Citizens, and we have the 40-bed assisted. We have an adult day program. We do independent housing. We're a full senior service agency. We really believe in special buddies. We have 2 of our residents who work well with them. And during COVID, when they weren't able to see them, it really was hard on them. But once we released all of the restrictions, getting them back into the community was really important. Mostly because it's somebody they trusted, and they call them their buddy. They don't call them a caregiver. But they really, in actuality, that's what they are, because they have to go through a background check, and they, you know, it's important to make sure all those pieces are in place, because there's so much room for exploitation in this field that you really need to go through an agency with it. But getting them their exercise, if they're taking them to art museum, I mean, because we have an eclectic community, the art museums are fantastic. It just takes their mind off everything. And it's really important for that wife to still get her guardianship paperwork and just pull back a bit, because what she's doing is she's enhancing the aggression.
Yeah.
part of dementia, and really you never want to go there. And get them to a senior center where he can get involved in other things that are not around the house, because that's what's causing a lot of the confusion and just
We're
basic.
gonna leave there in a few minutes.
So
Great.
a lot of depression going on right now, it sounds like, with him.
Yeah, I'm sure there is. It sounds really awful
I'm
for
almost
him.
done.
You know, the fact that he has a friend, I think that's probably who I'm going to go to, because one of the things that his wife says is he will not allow anybody in the house. And he's got apparently he's been hoarding quite a bit. And she says it's piles of stuff all over the place. So, you know, that's one of the things, but I agree with you about backing off. I've tried to get her to do that. She goes over every single day and is there for as long as she can. And so it's she's so concerned about his safety, so concerned that he's going to give away money, so concerned. So, you know, that's where I've been putting my energy, is trying to help her back off a bit.
She needs some support as well.
Yeah,
I
absolutely.
would highly recommend getting her involved in some other avenue. Definitely getting her set up with a guardianship will take care of the fear of the money exploitation. So that would help her in that regard.
Yeah.
But I have 2 residents that are hoarders that their special buddies go through, and they work with them and they have them donate that stuff to like our Salvation Army, and they include that person in that, so they are doing it with them, so it becomes like something they're doing that's positive.
Yeah, that sounds like a really good
pretty
program.
successful, and we have 2 of them, so I know it's tough to get it started, but really you just have to find the right mix. And a male with a male works really well with us, but I've also had female caregivers as well work with our clients.
Unknown color.
Yeah. Okay. Well, these are really good suggestions, and I appreciate it a lot. We'll see what we can do.
Yeah. Well, yeah, and it's an ongoing process, right? That revisiting things as things unfold. Yeah. So again, thank you, Gay, for bringing this case. Thank you, Reza, for the didactic. We're right at 2:01-ish. I also just want to point out there are a couple of other things in the chat about really, really thoughtful ways to approach very difficult topics. And boy, driving is one of the most difficult.
Yeah.
So we will be happy to synthesize those and send them to you. So
I would love that. Thank you very much. Appreciate it.
all right.
Yeah. Great.
Thank you all for your participation, and we'll see you in 2 weeks.
See you in 2 weeks. Thank you.